Okay, well, we'll make a start. It's 5 past midday. So, welcome everyone to pediatric teaching today. I wanted to talk about severe asthma in children. We haven't spoken about that much, but asthma is increasing in prevalence in all countries, especially in low and middle income countries for a variety of different reasons. And we'll talk about that. I want to focus a lot on the management of severe asthma, and first of all, I'll say a bit about the background to asthma, the epidemiology and the immunology of asthma, but most of it will be about the management of moderate and severe asthma and what we can do for these children. I mean, just to be clear, often it's hard to make a distinction between asthma and other respiratory infections, and often miss um, we often miss children who've got asthma because we diagnose it as being pneumonia or bronchiolitis or something. There are some clear things about asthma that make it distinct from pneumonia, for example. It's an allergic hypersensitivity of the airways to lots of different things. Allergens, like you can't always identify the allergen, but often there's some sort of allergen, whether it's dust or infections or molds or other allergens. Ryegrass is a common one. And unlike in pneumonia, where the alveoli are full of fluid and full of mucus, in asthma there's predominantly airflow obstruction. There's constriction of the smooth muscle of the bronchi, and it's reversible. So it's not there all the time. It's reversible, and it's reversible usually with beta 2 agonists. But there is the things that make it a bit more like respiratory infections is that there is inflammation and there is mucus overproduction. So these patients with asthma don't just have bronchial um, bronchoconstriction, but they also have massive mucus production. And and some children have more predominantly bronchoconstrictive asthma, and some children have more predominantly mucus-producing asthma, but they all have both components, and certainly they all have bronchoconstriction. There is a sort of hyperinflammation, so sometimes children can have fevers, and there's also a lot of overlap between respiratory infections that often trigger asthma in susceptible patients, and so they look like they've got a respiratory infection, but they have some other features. As I said, it's reversible, it's episodic, usually episodic. There may be some underlying chronic asthma as well. So the child always has um, more constricted airways than is normal. And we'll talk about how to assess that sort of towards the end. As I said, it's increasing in many countries, asthma, and partly that's because of pollution, and that can be outdoor pollution in cities, especially where there's a lot of smog or smoke, or it can be indoor pollution where because of the exposure to cigarette smoke or to other smoke from um, burning of fossil fuels, for example. There are certain groups of children that have a particular predisposition to asthma. So kids with other forms of allergies, for example, that's very common with eczema, skin rashes, eczema, or hay fever. But then there's other risk factors for asthma, including early life exposure to farm animals. That's a sort of unusual one, isn't it? Because you almost think that that might protect the child from asthma, but no, that seems to be a risk factor. We see a lot of children now with asthma who've got some sort of problem around the neonatal period, like they're low birth weight babies or preterm babies. Maybe they've had some damage to their lungs at the time of birth, and they're more at risk of asthma later on. Children born by cesarean section also have an increased risk of asthma. No one quite knows why. If if babies are exposed to antibiotics in the neonatal period in the first couple of weeks of life, they seem to be more at risk of asthma, and that probably has something to do with the healthy microbiome and how that's disrupted in its development. Mold exposure is very common, so children who live in moldy houses where there's a lot of mold on on the walls, on the curtain material, in carpets, etc. They're more at risk of asthma. And as I said, children who are allergic to other things, and also the respiratory viral infections, which are unavoidable in the first year of life. But one in particular, respiratory syncytial virus, that seems to have a relationship to the subsequent development of asthma. So we see lots of children who've had a couple of episodes of RSV in the first year of life, and then inevitably they go on to get, or often they go on to get episodic bronchoconstriction, asthma in the second and third year of life. And it's not because of RSV this time, it's just because they're getting asthma. So there's lots of risk factors for asthma, and the same risk factors won't all apply to the same patients. There'll be lots of different risk factors for any individual patient. And for some children, there's no particular risk factor at all. Although smoke exposure and early life RSV and not being breastfed, they seem to be common risk factors in many, but not all children with asthma. The, the, it's good to know something about the pathogenesis of asthma, partly because it's often asked at a part one level in understanding the immunopathology, the immunology and the pathology of asthma. And it's not entirely clear why asthma develops, but there's something to do with the immune response to certain allergens, whether they're viruses or dust or grasses or pollens, etc. And mostly well, there are two types of, as you know, there are many sorts of lymphocytes. There are T cells and there are B cells, and the B cells produce antibodies, and the T cells, we know about the T helper cells, the CD4 cells, and the T killer cells, which is the CD8 cells. We can break the T helper cells down into two types of T helper cells, or at least they may be the same cells, but they can have a different response depending on what response is switched on and switched off. And there's a response called the Th1 or T helper 1 response, which is the common response from T helper cells that you get when exposed to bacterial infections. And they produce certain cytokines. The ones that help fight bacterial infections are interleukin-2 and tumor necrosis factor. They're the two ones produced by the Th1 response. But there's another response called the Th2 response, and that produces other cytokines, interleukin-4 and interleukin-13, and they're not there to fight bacterial infections, but they stimulate plasma cells to produce immunoglobulin E, and they stimulate mast cells to release other chemical mediators of inflammation and allergy. And it seems somehow that children who are a bit more predisposed to a Th2 immune response from their T helper cells are a bit more likely to get asthma. And you can get a stimulation of a T2 Th2 response, that T helper 2 response, especially when exposed to those allergens I talked about before: house dust mite, cockroaches, animal dander, animals who shed hair, and other allergens. And that leads to a Th2 response, and that leads to increased IgE, and often IgE stimulates eosinophils. So remember that in children, people who are allergic, they'll often have a high eosinophil count, not always, but often, and they're more likely. It's a sign of atopy, as well as it being a sign of parasitic worm infestation, as you know. There are some children that don't have a Th2 type of asthma. They have what's called neutrophilic asthma, which just means when they get asthma, they have a neutrophil response, a bit like in a bacterial infection. It's not really clear why, but what is clear is that things like I talked about, smoke exposure, respiratory syncytial virus, particularly infections, mold, dust, and grasses lead to asthma, usually by that Th2 response, that T helper 2 response. I only tell you these things because sometimes the immunopathology of asthmas are asked in part one exams, and it's useful, I think, to know this background, and it helps to distinguish it in some ways immunopathologically from other forms of respiratory infections like pneumonia. Um, yeah, I want to get on to treatment now, and I want to focus this talk more on the management of moderate and severe asthma, and so there are many children that have mild episodic asthma. They get some salbutamol by a metered dose inhaler and a spacer, or they get some salbutamol via a nebulizer, and they're okay. That breaks their asthma, and their bronchospasm is broken, and sometimes they need some steroids for a few days. But I wanted to really focus on children who've got moderate and severe asthma and explain what the treatments that can be given are, because I know there's more children getting asthma, and it's good to know how to escalate treatment in such children. Firstly, there is a stepwise escalation of treatment that goes from mild, moderate to severe, and also even within those categories, not every child who's got severe asthma will need every therapy I'm talking about. There's a stepwise increase in those sorts of therapies. But let's talk about moderate asthma first, and and um, and usually with children with moderate attack of asthma, they come into hospital, they've got moderate respiratory distress. They may be able to just speak briefly, but not able to talk in long sentences. They've got prolonged expiratory phase and a prolonged wheeze. Usually those patients, they settle down with salbutamol by nebulizer or even a metered dose inhaler every 1 to 2 hours. And I'll show a metered dose inhaler a little bit later, but you've all seen a puff, we call them puffers. Um, those children need around somewhere between 6 and 12 puffs. If they're under 7 years of age, they usually need 6 puffs. If they're over 7 or over 10, they need 12 puffs. And the dose of 6 to 12 puffs has been worked out fairly well. It seems much more than what you'd normally give. If a child's got mild asthma, you might give 2 or 3 puffs of the metered dose inhaler. But if they've got moderate or severe asthma, then they need some more. And remember, it's ideally using a spacer, because children will be able to inhale that much better. If you don't have a metered dose inhaler and spacer, then using a nebulizer is fine. In children who've got moderate, certainly with severe asthma, those children are almost always hypoxic. So you need to drive the nebulizer with oxygen. If you're driving it just with air, with room air by a compressor, then the child will be getting less oxygen than what they would if they were just getting a face mask or they were getting nasal prongs. So if you are doing that, if you are driving it with a nebulizer and a compressor, then make sure the child's on oxygen as well, usually nasal prongs, and they can still have the nebulizer as well. But don't stop their nasal prongs to give them nebulized salbutamol with a compressor, because in a compressor you're only giving them 21% oxygen. Most children who've got moderate asthma benefit from steroids, and that can be given every 12 hours or occasionally, certainly for severe asthma, giving it every 6 hours is important. And then you de-escalate that therapy. Once they're stabilized, which usually takes 12 to 24 hours, once they're stabilized, make sure you de-escalate the steroids, and usually 3 to 5 days of once a day steroids, 1 mg/kg of prednisolone is enough. There's another drug we often use for moderate asthma and severe asthma, and that's called ipratropium bromide, and that's an anticholinergic agent. Anything that anticholinergic and yeah, anticholinergic drugs or beta-2 agonists, they do the same thing. They increase cyclic AMP, and they reduce smooth muscle contraction. So they're aimed to reduce the smooth muscle contraction of the bronchi. And Atrovent is quite good. And if you're it's an adjunct to salbutamol. If the child's not quite getting better with salbutamol, then you can add Atrovent or ipratropium bromide. That's usually given for a child with moderate asthma every 6 hours. For a child who's got severe asthma, then every 4 hours. But as you can see, as a child is getting better, you reduce the therapy usually slowly over a day or so. If a child's getting worse despite the therapy, then you escalate the therapy more. Again, just for in terms of pharmacology and um, basic science, it's good to know how these drugs work. I've talked about how ipratropium bromide works, an anticholinergic agent, but beta-2 agonists, so salbutamol, there's other ones called terbutaline and other things. Beta-2 agonists work by the activation of adenylate cyclase. Again, that's an enzyme that increases cyclic AMP and leads to relaxation of bronchial smooth muscles. So everything leads to the relaxation of the smooth muscles that sort of concentrically surrounds the bronchial wall, and when that contracts, you get bronchoconstriction. But increased cyclic AMP through either beta-2 agonists or um, anticholinergic agents like Atrovent, that they cause relaxation of the smooth muscles. There's a few other mechanisms of beta-2 agonists. So salbutamol might also decrease mast cell mediated response. So remember we said the mast cells, the plasma cells release IgE and stimulate eosinophils, and the salbutamol might dampen those things down. I'll talk about this other therapy, long-acting beta agonists, LABA, plus corticosteroids. I'll talk about that when we talk about chronic asthma. But I want to just say something about corticosteroids and how they work. They're anti-inflammatory. So remember I said asthma is an inflammatory disease where you've got inflammation and mucus hypersecretion as well as bronchial constriction. Steroids all act by protein synthesis. And if you remember that for steroids for anything to lead to protein synthesis, it has to give a change, a turning on of certain genes then transcribe messenger RNA that gets translated into amino acids, then produces protein, and that can lead to increase in enzyme production, like a cytokine called IL-10, which inhibits, while some cytokines increase the inflammation, some reduce it. And IL-10, which is produced when you give steroids, inhibits these other pro-inflammatory cytokines and reduces T cell activation, reduces mast cell activation, and eosinophil function. So steroids do dampen down that inflammatory response in asthma, but they take a little while to work. They take a few hours to work to generate that protein production, whereas salbutamol, of course, works more quickly. So in a child with moderate or severe asthma, that's why we're giving those therapies. In a child with severe asthma, then they're almost always hypoxic, and those children can need salbutamol every 30 minutes or every hour, or even continuously. There are some children that you fill up the nebulizer and they finish their salbutamol, and within 5 minutes they've got bronchospasm again, and you have to give them more. Just put some more, another 5 milligrams in the nebulizer. Remember, I said in severe asthma, if you possibly can, then nebulize with oxygen. If you can't do that, then just make sure the child's on oxygen as well, nasal prong oxygen, as well as having the face mask for the salbutamol. Steroids, I've talked about the mechanism of action. It usually in severe asthma or life-threatening asthma, we would give it every 6 hours. If possible, we'd give ipratropium bromide as well, and again every 4 hours as usual. And if you've got a child who's really critical, and you've got ipratropium bromide or Atrovent, then you can give it 3 or 4 doses in a row, and then every 4 hours. Don't give it too much, but unlike salbutamol, you can't keep giving it continuously or even more often than 4 hourly. But with salbutamol you can, but with Atrovent you should not. If a child's all still struggling, despite salbutamol and steroids, then there's now good evidence that using magnesium will help. And of course, that's an intravenous therapy. And so the child's got to have, but if they've got severe asthma, they've got to have an IV. And you can, um, this is magnesium sulfate, 50% or 49.5%, I think comes as. And you should give 0.2 mils per kilogram. So the 10-kilo child with bad asthma gets 2 mils of IV magnesium over 30 minutes. So you have to dilute it and give it slowly. It's usually given over 30 minutes to reduce the vasodilatory effect of magnesium. That can sometimes drop blood pressure, but it doesn't usually. You can repeat the magnesium every 6 hours like that. And it's been shown in severe asthma to be a very good adjunctive therapy. There's some other treatments that beyond magnesium, I put a line there because when you get into aminophylline or an adrenaline infusion or IV salbutamol, then you're getting to the next level therapy. I would say second or third line therapy for severe asthma. But you can give aminophylline 10 milligrams per kilogram every 6 hours. Usually infuse it over about an hour, again, half an hour to an hour. And again, that is to reduce the side effects of the drug. About a third of all children vomit when they get aminophylline, but it is a good bronchodilator. And all of these therapies, whether it's salbutamol or ipratropium or steroids or magnesium or aminophylline, they all work in different ways. And that's the benefit because you're giving, if a child's got quite severe asthma and they're slow to improve, then you want to try a different mechanism of action with a different drug so that you see if they improve. Most children with severe asthma don't need all of these therapies, but some children will need all or most of these therapies, and you stepwise escalate them and if a child's not responding well to the initial therapy. For some children with asthma, I run an adrenaline infusion, but usually that's after they've had magnesium and usually after they've had aminophylline as well. And if they're not improving, then you can either run an adrenaline infusion or some IV salbutamol. If you've got salbutamol in the IV preparation, then that's not too hard to do. 5 micrograms per kilogram, just again, give it slowly over 10 minutes. That's not too hard to do. There are some children that have anaphylaxis or they have a good history of like food allergy and they've got asthma. And in all those children, adrenaline is a good thing to do. I'll just talk about how magnesium works. Again, you don't need to know this too much, but it works in many ways. It also has an anticholinergic effect. It blocks acetylcholine release from cholinergic nerve terminals. So just like ipratropium bromide, it reduces acetylcholine bronchoconstriction. It also blocks these receptors called NMDA receptors, and that is also why ketamine works in asthma. Ketamine, I mean, you know about ketamine, the sedative agent, the anesthetic agent, and that's an NMDA antagonist as well. So that's why ketamine works in asthma, and it may be one of the reasons why magnesium also works in asthma. We'll talk about the role of ketamine in a little bit later. It may block calcium influx into cells, which also causes smooth muscle contraction. And so that's the effect on bronchial smooth muscle, and it has an anti-inflammatory effect as well. Magnesium does. It'll reduce mucus production. It decreases remember we talked about histamine release from mast cells being triggered by the Th2 receptor response, and it reduces neutrophil activation. So anything that blocks, dampens down inflammation may be beneficial. It's highly effective in asthma, in moderate and severe asthma, but often people have tried to use it in bronchiolitis, not really with the same sort of effect. So it seems to be more effective in asthma. As I said, the dose is 0.2 mils per kilo IV over about 30 minutes. So just slowly, a slow push of that. And so if you've got a child who's 10 kilos, the dose is 2 mils, just 2 mils of 50% magnesium sulfate, and I usually dilute it to 10 or 20 mils and then just syringe it through. If the child's 20 kilos, then the dose is 4 mils only of 50% magnesium sulfate, and you again infuse that over slowly over 30 minutes and measure the blood pressure if you can during the infusion. I mentioned that there are some children that have severe catastrophic asthma. They get very, very sick very quickly, and it can be related to anaphylaxis if they are exposed to some sort of allergen, whether it's certain foods or some other allergen. They can get very severe bronchospasm, and in those children, it's very useful to treat them as if they've got anaphylaxis and give them a deep intramuscular injection of adrenaline. I know of several children whose lives have been saved by getting an IM dose of adrenaline at the time they had severe bronchospasm. As you probably know, many children with allergy, they may even carry around a dose of adrenaline with them just in case they get exposed to such an allergy. But that overlap between asthma and anaphylaxis is increasingly common, and we may see it as well. If you're giving adrenaline in asthma, then mostly, to start with at least, we only have a peripheral IV line, and there is a way to do that safely. As you know, adrenaline can lead to extravasation, and it can lead to necrosis of veins. It's not good to keep to use it for long-term treatment with adrenaline, but for short-term, even for 4 to 6 hours, you can run adrenaline in this way. You make up with a litre bag of normal saline, put 6 milligrams, that's 6 vials of adrenaline into a litre bag, and then run it. It's very slow. You really need an infusion pump, but you run it at 0.5 mils per kilo. So again, the 10-kilo child, you're going to run it at 5 mils an hour. That's all, 5 mils an hour. And with that, they'll get 0.05 micrograms per kilogram per minute of adrenaline. Now, that's a prescription and a dose of adrenaline that's fine for children who've got a variety of different conditions, including septic shock or severe myocardial impairment and anaphylaxis and asthma. Again, these are treatments for critical asthma, not for moderate asthma. You don't run adrenaline for that. But for children who've got severe or critical asthma, they can benefit from an adrenaline infusion if they're not responding well to those other therapies. I always think it's good to have some sort of indications for when you call your ICU to help out, and it is important that you know what thresholds to do that. It's based on the patient's clinical state and the response to treatment or the lack of response to treatment. It's not based on what their blood gases look like, but if their clinical state is not improving or deteriorating, or they're entering, if you're using a monitoring and response chart, a color-coded chart, if they're entering the red zone in any of the variables, then it's really good to have them managed in the ICU where they'll be able to get this sort of treatment, and hopefully they won't need any more escalation. The ICU is not only for children who need intubation or anything like that. It can be for close monitoring. Any child who needs salbutamol every half hour, they really should be in an area where they can get really close monitoring in the ICU. And there are some drugs that it's really only safe to be giving in the ICU, like IV aminophylline or IV salbutamol or IV adrenaline, or even if children get worse, then they can be ventilated in some ways with asthma. Wherever they are, whether they're in the general ward or in the ICU, they can be monitored with oxygen saturation. You obviously monitor their chest indrawing and their accessory muscle use, their respiratory rate. It also can be useful to monitor their peak flow. In children that are not as critically unwell, then you can monitor their peak expiratory flow rate. We'll talk a bit more about that again when we talk about sort of the management of chronic asthma or long-term management. In children who are on these sorts of therapies, on regular half or 1 hourly salbutamol and they've had several hours of this, it's very important to look for complications. If any child's on salbutamol or adrenaline, then sometimes they can lead to complications, especially hypokalemia, low potassium, and sometimes lactic acidosis. They can be an effect of salbutamol or adrenaline. And the low potassium is quite important because if they get hypokalemia, then their muscles will be weaker. They're including their respiratory muscles. So it's a complication of salbutamol that we can observe and avoid. As I said, many children, not many, but some children with severe asthma who are on lots of salbutamol get a lactic acidosis, and sometimes they get a sort of hyperglycemia. Their blood sugar is high and their potassium is low, and that can be caused by lots of sympathomimetics, like lots of salbutamol. That can lead to, because of the acidosis, it can lead to hyperventilation because the child's breathing faster to blow off more carbon dioxide, and that can be misinterpreted as a deterioration in their asthma. So sometimes, if they've got that, if they've got a lactic acidosis or they've got other features, if they don't have too much in the way of wheeze, then the solution is not to actually increase the therapy, it's to reduce it. And we see a number of children that get admitted to the ICU, and actually they've had a lot or too much salbutamol, and what you need to do is cut back on it and listen to their chest to make sure that their wheeze doesn't return. I don't mean stop it completely. You never abruptly stop um, uh, asthma therapy in children who've had moderate or severe asthma. Never do that, because they will have a rebound effect, but go down slowly. There are some children, it's rare, but maybe 5% of children with severe asthma who need to be intubated. I won't talk too much about that today, but if a child, despite 100% oxygen through a face mask, high flow oxygen, plus really good bronchodilator therapy with what I've outlined, and some who've had a trial of high flow oxygen or CPAP, if they're still hypoxic, or if a child is just exhausted, they've got severe respiratory distress and or if they're unconscious at any time, or if they have periods of apnea. These two, at any time, you should always, any child who's got asthma and is unconscious is not going to last very long, so they need to be intubated. And it's very important to be able to identify such patients. If you are, again, this is, I'll touch on this briefly, but if you are going to intubate a child with asthma, then you need to be well prepared. If the child's getting worse, then it's good to be well prepared. And many of these children are a bit under volume because they haven't drunk anything for several days, and they've got high insensible losses because they're breathing very fast. So to give them, to make sure they're not hypovolemic or dehydrated before you intubate them is important, because all the drugs that you give when you intubate a child will drop their blood pressure somewhat. Always give salbutamol beforehand, and as much as you can, what we call pre-oxygenate them. Have plenty of time with the highest amount of oxygen. Try to get their oxygen levels up to a high level. And then when you intubate them, then again, choosing the drugs you use very carefully. And there are some drugs that can drop your blood pressure more, and there are some drugs that can help your asthma a bit more. And so whenever I intubate a patient with asthma, best to use, I always use ketamine because it has a bronchodilatory effect. Remember we said it's an NMDA receptor antagonist, so it causes some bronchodilation. I usually give a little bit of fentanyl or some other opioid to try to, reduce the just cause a bit more analgesia from ketamine's a good analgesic as well as a sedative and anesthetic agent, but I usually give a bit of fentanyl or some morphine. No, not morphine usually, but fentanyl, and then a muscle relaxant. And once you have done that, once you've anesthetized the patient, you need to then intubate them as quickly as you can. And so it's really important to have a skilled person, a person who's skilled in intubating critically ill patients in the room, an anaesthetist usually. It's not the same as a child who's arrested. This is a patient who you're inducing, and they're likely to get worse before they get better. And with children with asthma, then use the largest fitting endotracheal tube. Because they've got such severe airflow obstruction, they don't need to have a big leak around the endotracheal tube. You'll never ventilate them. So, put in the tube that's right for their age and maybe half a size bigger. Certainly don't go to a smaller endotracheal tube because you just won't ventilate them. They'll have such severe obstruction. There are some children that once you intubate them, you can't ventilate them. And that's partly because they have what's called dynamic hyperinflation. Their lungs are so full of air that for example, this child, you can see how these are two different children, but you can see how over distended their lungs are. Right? This was one child even before the child was intubated. The lungs are very over distended, and this one is a over distended lungs um, after the child was intubated. And you can see that it's very hard for this child to breathe out. And so you sometimes have to just disconnect the ventilator, put lots of oxygen through the ventilator, but not pressure, and just allow the child to breathe out. And sometimes that requires even some external pressure on the side of the chest to deflate the chest so that the child can breathe out. And then you start from a more deflated chest, and then continue to ventilate the child. Often after we intubate a patient with asthma, we get this problem of dynamic hyperinflation because of their increased intrathoracic pressure. When that happens, because of the high pressure inside their chest, their venous return to their heart reduces, and they may drop their blood pressure because of that. As well as that, you've given them drugs that cause their blood pressure to drop, and they may not have been drinking well and have high insensible losses. So for all those reasons, after you intubate a patient with asthma, sometimes you get blood pressure drops and they're hard to ventilate. And the solution to that is um, to again disconnect the ventilator. Don't put pressure in it, just lots of oxygen, and allow the lungs to deflate. I always listen with my stethoscope to hear the lungs deflating and wait until the lungs are deflated, and then you can give another breath. The trick, not a trick, it's that oops, sorry. If you ever have to ventilate a child with asthma, then the key to it is to ensure that they have enough time to exhale. Well, one of the problems is we don't give children with asthma enough time to exhale, and so therefore they've got lots of gas trapping in their lungs and they can't exhale. So you have to have a very low respiratory rate so that they've got enough time to breathe out. And I won't go through the details of it, but you try to limit the pressure that you're giving into the lungs, and you reduce the rate so they've got enough time to exhale. I always sedate them with ketamine because it has a bronchodilator effect, and usually with fentanyl if you've got it. I try not to muscle relax patients with asthma because they are particularly prone to getting muscle weakness. And if you give them muscle relaxants for many, many days and keep them paralyzed, then often with the steroids and other things, maybe the low potassium, they'll have muscle weakness. So try not to relax them, but try to sedate them with ketamine, usually, and higher doses than what you'd normally use. But the key to it is to allow the child, ideally, to breathe spontaneously, but to have enough time to exhale, not to be on using a usual respiratory rate for children, and not give them enough time to exhale, because then they'll get this thing called dynamic hyperinflation or massive overdistension of their lungs, like I showed you in those X-rays. If you suspect this gas trapping, I won't go through this too much, but if you suspect this gas trapping, then you should increase the time that they have to exhale. That's the most important thing. And then, as I said, often sometimes you need to disconnect the ventilator, give them plenty of oxygen, and then just leave it for 30 seconds or even up to a minute to allow them to exhale. Then usually not that long, but just try to exhale as much as they can. You can repeat that every hour if they have this dynamic hyperinflation. But the key to it is to uh, uh, have the respiratory rate relatively low so that they have a lot of time to exhale their full breath and then get another breath. So a respiratory rate of 12 to 14 would be usually a starting point. Sometimes you need to go lower, and sometimes you can go higher as their airflow obstruction goes down. But occasionally, if they've been very critical, after you intubate them, you just need to disconnect and press on the chest to allow exhalation. Don't press on the front of the chest, just press on the side of the chest gently and help them exhale. And it usually works. It usually takes 10 or 15 seconds, and then you can give them another breath. Okay. Some children, before you intubate them, will benefit from what's called BiPAP, which is non-invasive ventilation with a mask. They still need all their bronchodilators, whether they're intubated or whether they're on non-invasive ventilation, mask ventilation or not. They need to keep having bronchodilators. But BiPAP, this concept of BiPAP, which is like CPAP, but it's got two levels. It's called bi-level positive airway pressure, BiPAP, not continuous positive airway pressure. They have CPAP, but they have another level of pressure. And that can have a direct bronchodilator effect because it can, if you like, push open the bronchi. It can recruit collapsed alveoli because when the bronchi are um, uh, narrowed, then often the airways, the alveoli distal to that, are collapsed, and it can recruit those alveoli. It can improve VQ mismatching and reduce worker breathing. So the children often feel much better if they're on BiPAP. And one of the key things I find is that if a child can sleep when you put them on BiPAP, if they can finally get to sleep after being exhausted for 16 hours of breathing in a heavy way, then you know that's giving them benefit. If they can sleep, then usually their worker breathing, the effort they have to put in to breathe is better. You need to make sure they're asleep and not unconscious, but often it's not uncommon that such children are able to get to sleep. If you are going to use BiPAP or CPAP in patients with asthma, then it's it's tricky to know when to give it. Not too early, because if don't use it on children who've got mild or moderate asthma. They don't need it. They'd be fine with just bronchodilators, but they're not too late. Not when they're severe and needing intubation. If they're unconscious or apneic, then the BiPAP won't help. CPAP won't help. No way. You really got to give it to those children in the middle that are getting worse, but not at that point yet. So if a child is not responding well to bronchodilators or steroids or magnesium, then I usually, if they're still hypoxic, then I try them on CPAP or BiPAP. Most children who you try and BiPAP, as I said, they can't be children who need immediate intubation, and they can't be children who have, they're unconscious or having apnea. They can't be that. For some children, you can't fit the mask well, and some children have lots of respiratory secretions, and that can pool in the mask, and they can aspirate that. So if you're having to suction them a lot with their asthma, then maybe they won't do well on BiPAP. It's still worth sometimes trying, but yeah. There are different ways to give CPAP, and this is you've seen the Diamedica machines for CPAP for neonates. Well, this is just an older child, not who had asthma, but an older child who needed CPAP. So you can give CPAP to children who are older, infants and older children, using the same method. This is bubble CPAP. Mostly for asthma, what's used is like a a CPAP or a BiPAP ventilator, and some intensive care units around the country have them. I won't go through the different types of CPAP, but they're CPAP or BiPAP, but usually a child with asthma, they would benefit more from BiPAP than they would from CPAP. When you're setting up a BiPAP in children with asthma, it's usually you start with not high amounts of support. Just start with mild or moderate support, because then the child feels quite comfortable with that and they cooperate. So start with there's two levels, PEEP and what's called the IPAP. Start with PEEP, that's quite low, usually about 3 centimeters of water, and the IPAP usually about 7. And then you titrate that up a bit. If their respiratory rate's high, then you increase the IPAP and watch if their work of breathing settles, if they seem more comfortable. That's what you're watching for, to see if their breathing seems more comfortable. If they go to sleep, I usually think it proves that they've got reduced muscle fatigue and they're just more comfortable. The risks of using CPAP or BiPAP are that you may delay intubation, and that's not a good thing. If a child needs intubating, then they need it. So don't use it otherwise. Some children are a bit agitated with BiPAP, and it doesn't always work because they're agitated. And I'm always wary about sedating patients who've got asthma just to tolerate BiPAP. I don't think that's such a good idea. If they're on the verge of respiratory failure, then just intubate them. But again, you need the right people there to help you out. Any child who needs CPAP or BiPAP for asthma needs to be in an ICU environment. Right. So that's all I want to say about the acute management of severe or critical asthma. But I did want to talk a bit about touch on a few things about the long-term management of asthma. There's a number of things that have been proven to work now, and I think we should be incorporating them in the way we manage such patients. I'll just go through them. The things that have been proven to work are if children with asthma have a written personal management plan. This is a written personal management plan for one of the patients that I've looked after, and it's a simple plan that the child and the family can understand, and they can take it and show any healthcare worker about how their asthma should be managed when they're on good days and on sick days. Very important to teach families and children about their asthma. You should teach the child, because as children get to going to school, they need to be able to take their puffers to school, and so therefore they need to know how to use them, and they need to be informed. They need to be able to be the experts in their asthma. The other thing that's been shown to be effective, we often think that, well, a child with chronic or persistent asthma symptoms needs to be on Ventolin, but actually there's even better treatments for that. If a child's on lots of Ventolin, then that's not as a preventer. It doesn't really prevent asthma, but there's a type of preventer that's been endorsed by the World Health Organization, and it's what I spoke about before. It's an inhaled corticosteroid plus a long-acting beta-2 agonist, and it's called corticosteroid plus LABA, or there's lots of other names. One's called Symbicort. That's the one that's undergone the most research and has been approved by WHO, or Seretide. That's also a very similar drug. WHO has essentially approved as part of the essential medicines list inhaled corticosteroids and long-acting beta-2 agonists as preventative therapy for asthma. And so we should really try to get them, if we can, when we have a child who's got chronic asthma. One of those would be usually available. Seretide and Symbicort are these steroids plus long-acting beta-2 agonists. I won't go through them, but one's fluticasone propionate, fluticasone, or budesonide. They're the steroids, and the long-acting beta-2 agonists, salmeterol, not salbutamol, but salbutamol is short-acting, very short-acting. Salmeterol is longer-acting. Formoterol is also a long-acting. So you're combining long-acting beta-2 agonists with steroids. And there, usually the child takes 1 or 2 puffs once a day or twice a day, depending on the severity of their chronic asthma. And usually, or ideally, any child who's on that sort of therapy should be using a spacer. You can make spacers you can buy spacers, or you can make them um, uh, out of a Coke bottle, and all you're doing is filling up the chamber with the with the medication, and then the child breathes in for about half a minute the aerosolized drug in the chamber. As I said, these are particularly good for the prevention of children who've got frequent severe asthma or chronic asthma, symptoms of chronic asthma, like asthma when they exercise, or asthma at night particularly. I think this is very good for children to have if they've got asthma, and that is a peak flow meter. You can buy them at chemists. I know they're available at chemists, at a city pharmacy and other places. They're not very expensive, usually about 25 kina, I think, is a cost of a peak respiratory flow rate monitor. And every child with chronic asthma should have them, because they can record their peak respiratory flow rate. And it has two things it does. One is it helps the parents and the child identify if their asthma is getting worse on any particular day, and they might give them some extra therapy. But it also allows the child to get to know their asthma. They'll know what it feels like to be able to blow 300 or blow 250, or if their peak flow is down to less than 200, they'll know what to do about it. It's very useful for both monitoring and education. So I think all children who've got chronic asthma should be on these. They've gone out of fashion a bit because people use more fancy tests, but I think a peak respiratory flow rate in children is a very good idea if they've got chronic asthma. As I said, it's really important to have a home management plan, a written home management plan. I won't go through this, but this was a study in India of children with moderate or persistent asthma, and using home management plans, these children had fewer exacerbations and fewer absences from school, and their symptoms were generally improved, and they were happier. They had a better quality of life. We know that teaching children about their asthma works, and there's been studies done in other countries, in Jordan, for example, studies of asthma education in schools that improved knowledge of self-management, and the kids were more able to resist smoking, and they had better quality of life scores as well. So peer education is important. Getting children with asthma to teach other kids with asthma how to is important. And then lastly, I thought this was interesting, an asthma education program that was run. This is from the Netherlands, from a Dutch study, but this was run by a pediatric nurse and a physiotherapist who got children with asthma who had low quality of life. They were quite depressed or unhappy kids, and they put them through this 10-week program of group advice and reassurance, and individual advice about their asthma, and an exercise program. But instead of, most asthma exercise programs are trying to improve exercise tolerance, and that can, for children who are not very happy or have low quality of life, they can struggle to do that. What they tried to do instead was just do whatever activity the child could do for an hour. And these children had much better quality of life and happiness scores at 3 and 6 months. So they were able to cope with their asthma much better and had less anxiety about it. Right, so we've talked about the immunopathology of asthma, and we've talked about the treatment of mild, moderate, and severe asthma, and I've talked a bit about critical asthma and how to manage that, and we talked about chronic asthma and some of the principles of managing children with chronic asthma. There's a lot more you could talk about in regard to asthma, but I hope that's been useful for you today. I'll stop the recording now, and I'm happy to answer any questions that you might have. Thanks.